Dr. Rekha MC to present a memento as a token of our appreciation to Dr. Sunita DK and Dr. Archana Dambal.
For the next session, the proceedings will be taken over by Dr. Vishwanath K, the Secretary, API.
Respected Chairman, API, special invitees, all the delegates, senior members of API, a very warm welcome to this 41st Karnataka Chapter Association of Physicians of India, Kapicon 24. So we have been, now we had some 3 excellent lectures. Now we will come to the important session of orations. The first oration is Dr. Shashidhar Malak Reddy oration sponsored by MERT. To start this oration, I request the Chairman, API Karnataka Chapter, Dr. B.V. Murli Mohan sir, and our Honorary Treasurer, Dr. Mohan Kumar, to come up to the stage. To deliver this oration, I request Dr. Medini Alam to please come over the stage. I request the chairpersons to introduce the speaker, the orator, and about the oration, and put on the medallion to Dr. Medini, and then she can proceed with the talk.
Good morning, everybody. As a treasurer of API Karnataka chapter, I welcome you all here to the 41st Kapicon. This is the first oration. It's Dr. Shashidhar Malka Reddy oration. Dr. Shashidhar Malka Reddy is son of Dr. A.B. Malka Reddy. They have a nursing home called Malka Reddy Nursing Home in Gulbarga. Dr. Shashidhar Malka Reddy is born on 22nd January 1966. He did his graduation and post-graduation from MR Medical College, Gulbarga. He joined as a lecturer in 1995 in the Department of Medicine at MR Medical College, Gulbarga. He trained in neurology at NIMANS, Bangalore for 1 year, deputed by MR Medical College, Gulbarga. He was promoted as assistant professor at MR Medical College, Gulbarga in 1998. This oration was instituted in the year 2000 by A.B. Malka Reddy, former Medical Education Minister of Karnataka, in the name of his son, Dr. Shashidhar Malka Reddy, who himself was a physician who met with an untimely death.
Thank you, sir. I request the chairpersons to please put on the medallion.
Good morning, everybody. I am Dr. Medini Alam, Associate Professor of Medicine, WIMS, Billari. I thank API body members to give me this opportunity, and special thanks to our Secretary, Dr. Vishwanath Sir, to give this dais to me today. Now,
Madam, can I have the privilege of introducing you?
My topic is thyroid disorder in, sorry?
Sir, can I have the privilege of introducing you?
Thank you, sir.
So Dr. Medini Alum, who's been awarded the Dr. Shashidhar Malak Reddy oration, was born in 1981, completed her MBBS from JSS Medical College, Mysore, not far from here, and her MD from the JJM Medical College, Davangere. She's currently an associate professor at WIMS Bellary and consults at a couple of hospitals and nursing homes in Bellary. She got her fellowship in diabetes from the Royal College of Physicians, and we also her great work during Kapicon 23 in Bellary, where she headed the registration committee. She has a special interest in diabetes and thyroid and has published papers in ischemic stroke and neutropenia. Madam, it's a great pleasure to have you talk to us on this important topic. She'll be talking to us on thyroid disorders in pregnancy, their management, and some important considerations. And we look forward to hearing you as it's your area of interest, madam.
Thank you, sir. So I'll be talking about thyroid disorder and pregnancy. It's a huge topic, so I'll quickly go on with it. I'll also be talking about the management and key considerations of thyroid. So now we know that thyroid is quite different in pregnant ladies than in non-pregnant individual. Here this thyroid hormone, this HCG, which is produced from the this HCG, which is secreted during the pregnancy, is just similar to the TSH. HCG is similar to TSH. So what happens here is the HCG stimulates the thyroid to secrete thyroxine. Okay. This transiently increases T4, which has a negative feedback on the pituitary, which in turn reduces the TSH level. So this is little different than in the non-pregnant individuals. So what is the, let's talk in detail about the physiology in pregnancy. The estrogens which are secreted in pregnancy, they increase thyroid binding globulin, which increase in turn FT4 and FT3. So what happens here is the total T4 is more than 1.5 times than the normal non-pregnant individuals. Again, this HCG is similar to TSH. It again stimulates the release of T3 and T4, but transiently decreases TSH as a negative feedback, and moreover, which happens in 8 to 14 weeks of gestation. Next, what happens is there is increased peripheral metabolism of TSH in pregnancy, which can reduce FT3 and FT4. Also, there is a plasma volume, increased plasma volume in pregnancy, as we all know that. And more important, fetal thyroid is non-functional till 10 to 12 weeks. So the fetus depends on the mother for the thyroid level, thyroid hormone. Altogether, this increases the demand of T3 and T4 by 30 to 50% throughout the pregnancy. So this topic is quite important because here both the mother and the baby are going to be a part of it. Now let's see what happens with HCG and TSH. See, we already discussed this. When the HCG rises, the TSH falls, more so in the first trimester, but in the second and third trimester, the levels kind of come to the normal. Okay. Let's screening of the thyroid in pregnancy. This is very important. Whom do we screen in pregnancy and how to go about with it? So Endocrinological Society, they recommend these few indications whom to screen during the thyroid. So whoever has a past history of thyroid, had lobectomy or postpartum thyroiditis, they had a family history of thyroid disease, goiter, they had previous known Graves' disease, type 1 diabetes, infertility, and more important, ladies who had repeated miscarriages. Okay. This American Thyroid Association, they had a responder surveys whom to screen, and there was a voting. Of that, 74% said that let's do universal thyroid screening, 18 were against it, and 8% were unsure. But there was one analysis study which showed that for a case, if there is a very case-based screening, we can miss around 49% of pregnant women with thyroid. So this is pretty high, And then Foxy, what did they recommend? They recommend to screen all the ladies in the first antenatal visit with TSH. So that's a very good where we would not miss many of the thyroid disorders in first trimester itself. So let's go to the disease together. I will be dealing with hypothyroid, hyperthyroid, postpartum thyroiditis and also thyroid nodule. We all know this axis. When TSH increases, T4 decreases, it is hypothyroid. When TSH decreases, T4 increases, it is hyperthyroid. So these are the guidelines which are published by American and European Society and also the Indian Society. How do we go about the to diagnose the thyroid? So you Americans, they said that we can use as reference ranges which are derived from the specific pregnant population of that area. But if they are not available, we can use a reference limit of 4 as a upper limit. But ETA and ITS, that is Indian and European, they had a trimester specific guidelines where the Europeans and Indians, they said first trimester we can cutoff is 2.5 and second and third is 3. Even the Foxy went along with it. They said first trimester we can go with 2.5, second and third, for 3 as the upper limit. This is the disease burden which is there with hypothyroid in pregnancy. Worldwide it is 1.5 to 4, but India pretty high, 11%. So it's a quite a high burden in India. Okay. So what are the risks? So as I said, hypothyroid or hyperthyroid, it affects both the mother and the baby. So mother, she can have anemia, gestational hypotension, abruption placenta, postpartum hemorrhage, or she can have repeated abortions or abortions. Okay. Fetus, this is very important. Most of the fetus with the mother with hypothyroid are born preterm or with IUGR, or they may have respiratory distress, or most important of all, neurocognitive impairment. It is known that the child born to the mother with untreated thyroid have lower IQ levels than those born with the treated mothers. Okay, so the Foxy have recommendations. How do we go about with the lady coming to you at first antenatal visit? So first antenatal visit, we need to screen all the ladies with TSH, FT4 and anti-TPO antibodies. If the anti-TPO, and when do we do anti-TPO? Just one anti-TPO testing is enough. We don't have to repeatedly do TPO testing. If the patient is known hypothyroid and she is planning to conceive, we should see to that she achieves a euthyroid state before she conceives, and adjust the TSH between the lower reference limit and 2.5. If the lady is in need of a very high dose of thyroxine, then we should think there may be a resistant cases like GI disorders, H. pylori, atrophic gastritis or celiac disease should be thought of. Okay, how do we approach to hypothyroid according to the Foxy guidelines? I will go very step by step since this is very important. If we do FT4, TSH and TPO in the first antenatal visit, and FT4 and TSH is normal but TPO is negative, no treatment is required but review as and when clinically indicated. If FT4 and TSH is normal and TPO is positive, okay, here the FT4 TSH is normal but TPO is positive, monitor once every trimester up to second trimester. If the lady has an history of pregnancy loss earlier, her TPO antibodies are positive, and then low dose of thyroxine can be started to achieve an euthyroid, to keep her into a euthyroid state. If FT4 is normal, TSH is greater than 2.5 in first trimester or greater than 3 in second and third trimester, then she is known to be subclinical hypothyroid. What do we do now? consider LT4 if TSH is between 4 to 10 and even if the TPO is positive and and if the TPO is positive and TSH is between 2.5 to 4, then we can start on low dose of thyroxine. In case of if the FT4 is low, TSH is greater than 2.5 in first trimester and greater than 3 in second and third trimester, in whatever is the status of TPO antibodies, she is categorized as overt hypothyroidism. She needs to be started immediately on thyroxine at a dose of 1.6 to 2 microgram per kg to maintain a TSH less than 2 to maintain a target of TSH less than 2 milli-international units per liter. So this is all about how we treat the hypothyroid, and let's do thyroid autoimmunity. So this autoimmunity can be occur in the presence or in the absence of thyroid dysfunction. So Hashimoto's thyroiditis is the most common cause of thyroid autoimmunity, and these ladies usually have a TPO or thyroglobulin which are frequently elevated, and most of the time these ladies have an history of recurrent pregnancy loss. So this study says that those ladies which are having high antibody titers have repeated history of miscarriage and premature delivery. So what do we do? Do we treat these ladies? Yeah, it is better to treat these ladies with thyroxine so that she attains a euthyroid pregnant state and doesn't lose her pregnancy repeatedly. Let's go to hyperthyroidism. That's what all about hypo we finished. Now I'll talk about hyperthyroidism. So hyperthyroid is caused by many causes, but most important over here is excessive TSH receptor stimulation by Graves and gestational transient thyrotoxicosis. In this slide we see that the thyroid is stimulated both by TSH and also HCG, both by TSH and HCG. So HCG hormone can be over secreted in few conditions like choriocarcinoma, molar pregnancies, or even hyperemesis. So this causes hyperthyroidism, but it is not a true hyperthyroidism. We categorize it as gestational transient thyrotoxicosis. But if the thyroid is being stimulated by thyroid stimulating antibodies, it is usually Graves' disease. Okay, how do we approach? If we have a pregnant lady which TSH is with a lesser TSH, we do T3, T4, FT3, FT4 and TS antibodies. If T3, T4 are more than T3 and FT3 are more than T4 and FT4 with thyroid stimulating antibody positive, she is usually a Graves. But if FT4 and T4 are more than T3 and FT3 with TSA negative, she is usually a gestational transient thyrotoxicosis. Okay. So how do we differentiate between these two? This is quite important in the treatment aspects. Graves we know because it is an autoimmune and antibody mediated. Usually these patients have orbitopathy or diffuse goiter. They can present at any time during pregnancy, and usually the thyroid antibodies are positive. But in gestational transient thyrotoxicosis, usually it is in the first trimester, they have a family history, they do not have any signs of Graves, or sometimes can just be mild or absent of any clinical signs. Their antibodies are usually negative and they are self-limiting. Okay, so gestational transient thyrotoxicosis, how do we treat this lady? So this is usually a self-limiting. We do not need any anti-thyroid drugs for her. And we need to just treat the symptoms like hyperemesis with antiemetics, IV fluid and electrolyte abnormality. And serum T4 usually in these cases return to normal by 14 to 18 weeks of gestation. So next is Graves. So these receptor, I'll talk about thyroid receptor antibodies. These thyroid receptor antibodies are important in fetal aspects because they cross the placenta and stimulate the thyroid gland. Usually we measure them at 22 weeks of gestation in ladies who are already Graves or a previous history of Graves. She had an 131 treatment, iodine 131 treatment, or had a thyroidectomy or elevated TRAP previously. So what are the effect of Graves for mother and fetus? It can cause preeclampsia, pregnancy loss, maternal congestive cardiac failure, maternal thyroid storm and preterm labor. So baby can be born again with low birth weight or IUGR. Baby can have congestive cardiac failure, fetal and neonatal hyperthyroidism and low birth weight. So what is the incidence of Graves? This slide shows that the incidence increases as the maternal age of pregnancy increases. So what is the effect of pregnancy on Graves? So the Graves during first trimester is usually aggravated because increase in HCG. In second and third trimester it improves because of decrease in TSH antibody, and postpartum usually it is again aggravated due to increase in TSH antibody. So anti-thyroid drugs, we do not have many, but it is only propylthiouracil, methimazole or carbimazole. Among this, propylthiouracil is less teratogenic than methimazole and carbimazole, but only disadvantages, it can cause hepatocellular damage. But methimazole and carbimazole usually have a cholestatic jaundice which usually returns to normal once the drugs are stopped. But since the teratogenicity of methimazole and carbimazole is quite high, it can cause something called methimazole embryopathy with omphalocele, corneal atresia, aplasia cutis or athelia. This is the graph which shows with the study from Oshiara, which shows that the propylthiouracil methimazole is quite more, the birth defects with methimazole is quite higher than in compared to propylthiouracil in respect with controls. Okay, now we have a pregnant lady who was already a Graves' disease. How do we approach her? So once we have a Graves lady who wants to conceive, we should see to that she achieves a normal TSH before she conceives, or that is euthyroid state. If at all she undergoes surgery and her antibody titers, because of high antibody titers, we should request her to plan a pregnancy at least after 2 years. If she has undergone ablative therapy, we should ask her to not conceive at least for 6 months, and we should do a pregnancy test just before we give her iodine 131. So this is the management recommendations for the Graves' disease. Among this, propylthiouracil, American Thyroid Association, they were pretty worried with PTU, so they recommend PTU only in the first trimester, whereas second trimester they ask us to shift to methimazole due to the hepatocellular damage caused by PTU. But Endocrinological Society and even Indian Society, they recommend PTU as first line, since they are not much worried with the hepatocellular damage, as the incidence is quite low, about 0.1 to 0.4% in comparison. So, so we can continue with PTU throughout the pregnancy, whereas those ladies who are undergoing any surgical treatment for the Graves, all of them, they recommend to do it over in the second trimester. So if we are using beta blockers, because of any hypermetabolic syndrome, we can use propranolol at the dose of 20 to 40 mg every 6 to 8 hours, but it is important that we discontinue by 2 to 6 weeks, since it is since it is long-term treatment can cause fetal bradycardia, IUGR and neonatal hypoglycemia. So what are the signs of fetal thyroid hyperthyroidism? This ultrasound plays a very important role to detect fetal hyperthyroidism. Fetal tachycardia more than 170 beat per minute, IUGR, fetal goiter, accelerated bone maturation, or signs of congestive heart failure, fetal dry drops, they all are signs of hyperthyroidism in the baby. Next, going to postpartum thyroiditis. This is a very biphasic appearance with transient thyrotoxicosis appearing in 2 to 6 months postpartum, transient hypothyroidism in 3 to 12 months, and euthyroid by 1 year. So those ladies who have previous high antibody levels, or had a lymphocytic abnormality, complement activation diseases, or increased IgG, they are all prone for postpartum thyroiditis. So how do we treat them? If there is a transient thyrotoxicosis, we can give beta blocker. There is no need of ATT. And if there is transient hypothyroidism, we have to replace her with thyroxine. And if there is permanent hypothyroidism, she needs lifelong control of lifelong replacement of thyroxine. So if there is a transient hypothyroidism, we can give her for 12 to 18 months and then stop. So thyroid nodule, usually it gets aggravated if there is a pre-existing nodule. Most of the time it is benign, but sometimes it can be malignant, and it can, if it is a papillary or follicular carcinoma, then we need to suppress the TSH by and maintain a TSH of 0.1 to 0.8. In medullary carcinoma, less than 2.5. These nodules, usually we can diagnose by FNAC and treat them after the delivery. If at all patient needs surgery, we can approach the patient at second trimester. So here is a case. I think this is with a 25-year-old primate with 7 weeks of gestation, asymptomatic, no goiter. Routine investigation shows abnormal TFT and FT4 of 0.8, TSH of 74. So what is the diagnosis? This is a pretty easy case. I put it for the PGs. Okay, anybody? This is hypothyroid and we need to treat her. Okay, we'll go with this case. Here is a 26-year-old female with 8 weeks of gestation who presents with 3-week history of nausea, vomiting and palpitation. She has weight loss of 2 kg, unable to tolerate solid food, mild hand tremors, with pulse rate of 104, thyroid normally palpable but no bluing, serum TSH 0.02, T4 18. Do we treat this or not treat this? She doesn't have to be treated. She's gestational transient thyrotoxicosis. Usually it settles down. Thank you.
Thank you so much, madam. That was a very comprehensive coverage of a very difficult topic. You spoke to us about the different thyroid disorders in pregnancy and how one approaches them, and the important fact that there is a huge burden of this disease in India as compared to the West. So we should be picking it up and managing it more often. And of course, the effects are not only on the mother, but also on the fetus. And of course, not addressing thyroid disorders in pregnancy in a woman who can conceive is another important cause of loss of fertility. So that's again a very important area. As this is an oration, we will not be entertaining questions, but I'm sure Dr. Medini Alum will be glad to discuss this with you over in the lunch and tea area. So thank you so much, madam.
Thank you, sir.
ಇನ್ವಿಟೇಷನ್ ಒಂದು ಕಾಪಿ ಬೇಕಂತೆ CM ಇನಾಗ್ರೇಷನ್ ಇನ್ವಿಟೇಷನ್ನು ಯಾರಿದ್ದಾರೆ ಇಲ್ಲಿ ಹೂ ಇಸ್ ಹಿಯರ್
Thank you, sir. Now we move on to the second oration. Dr. V.G. Nadagoda, Honor Lecture.